We're going to try again. This is your narrator, Barb Cochran. I'm not going to be on video, but you'll be hearing me. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center, and this is the 9th of our 10 lectures in the spring quarter Geriatric Healthcare Lecture Series. I think I've got that right now. We have one more lecture next week on integrative medicine, and then we will hopefully see you next year. Just a reminder to check in with your site coordinator if you are wanting continuing education units. You should also be completing a sign-up sheet, turning in an evaluation form, and if you don't have handouts for this presentation, check in with your site coordinator. I'm very happy to introduce to you today Jane Miller. Dr. Miller received her medical degree from the University of Oklahoma and her urology residency training at UW. After completing her residency, she did a fellowship in female urology and urodynamics here as well. Dr. Miller's clinical interests include female urology and urogynecology with particular expertise in urinary incontinence, including neuromodulation, interstim device, voiding difficulties, painful bladder syndrome, and interstitial cystitis. Her research interests are in interstitial cystitis and pain, and she is an ongoing participant in the NIH clinical trials on these. I'd like you to welcome Dr. Miller, who's going to talk with us today about urinary incontinence in the elderly.
Okay, sorry about that. I didn't unmute. Today, I am talking about urinary incontinence, and most of what I say today is basically can be discussed about any patients with urinary incontinence, but there are some unique issues with the elderly that I will try to point out in today's lecture. And I guess if there are questions, they will be asked at the end, but don't hesitate to ask. I have had this slide in my deck for a long, long time, and I cannot replace it because I can only find somewhat inappropriate urologic cartoons. This is about the safest I can get. So anyway, I frequently ask my patients, can you hold? That is not just a nursing obligation. Anyway, so when we talk about urinary incontinence, and this graph, you can see that you can see urinary incontinence in young and old, but obviously as we go from younger to older, you're going to see an increase in urinary incontinence, and most specifically, you're going to see an increase in the severity of that incontinence. This is a problem of both men and women, and actually about the age of, we always think of incontinence being, at least I do, more of a problem in women in the younger years and through middle age, but after you get to about the age of 60, 65, the men actually begin to catch up with us, at least in terms of symptoms of urinary urgency and frequency, maybe not quite as much as incontinence, but urinary symptoms become actually more of a bother for men as we get in the 65 to 85 years of age. So again, the other thing to notice in the elderly population, those elderly patients in the community have a much less prevalence of incontinence than in patients with nursing home. And the question is this a chicken or the egg? So are patients being placed in nursing homes, one of those issues being for incontinence? Clearly they're a sicker population, and incontinence can be related to and a cause of medical issues. So it's not just a bladder and urethral problem, particularly in the elderly. Incontinence can be a result of many, many factors outside of the urinary tract system. So we do see it much more commonly in nursing homes. So again, prevalence of urinary incontinence increases with age, but we like to think of it as being abnormal at any age. So if you remember back to that first graph, even in the 85-year-old plus patients, the prevalence was about 35, probably closer to 45%. So in no age is incontinence more prevalent than it's not. So anyway, it is an abnormal finding. Again, as I just talked about, result of diseases and functional issues are more likely as patients get older. But I do, again, think that oftentimes there are interventions. We may not be able to cure some of these issues in some of our elderly patients, but generally we can at least make it a better situation than when they started. One thing to also think about, you may think, oh, why bother putting these patients through treatment for their incontinence and their bladder overactivity? Well, there are secondary consequences of patients with particularly urinary urge incontinence. This picture alone kind of tells you that the rate of hip fractures actually goes up in these patients, and you might think, well, they're going to go up anyway. But if you have a patient who can't see very well, can't hear very well, is running to the bathroom in the middle of the night in the dark, the falls are a much more likely option. And so, again, there are secondary consequences to your incontinence, not just the leakage and the management of that alone. And we also, so think of it not just as the incontinence, but all the consequences of the incontinence. So the other thing we like to think about is, you think, oh, those medications are so expensive. Do we really need to bring someone in for those treatments and physical therapy? Is it worth it? Well, there is a huge amount of cost with just managing the incontinence alone, whether it be from pads, diapers, toilet paper, all the laundry, all the dry cleaning, all the subsequent, if there's any issue with skin breakdown, all those things play a role in terms of those sort of costs. The indirect costs, basically lost in productivity for the caregiver, time spent by a caregiver. And if the patient is working, I mean, there's lost time for them as well. And not to mention the intangible costs of, clearly there's a decreased quality of life, decreased welfare and well-being. And the classic kind of story I always hear from patients is, well, I really want to go visit my grandkids, but I don't want to get on that plane. I don't want to get up and have a wet seat when I leave. So clearly there are some real life consequences in terms of quality of life for these patients. Hopefully we can improve that. So to talk about urinary incontinence, and this is true whether you're 20 or whether you're 80, basically the anatomy doesn't change a whole lot. And so just in general, just a very simplistic look at the urine, what I'm talking about is the lower urinary tract, which includes the bladder, the prostate, the urethra, and the pelvic floor muscles in the men. And in women, you just have the bladder, you have the bladder neck, the urethra, and the pelvic floor muscles. So I frequently talk about the bladder and the bladder outlet. The bladder is relatively straightforward, but the bladder outlet is incredibly complex, and this is a very simplistic view of that. But when I talk about the outlet, that involves the bladder neck, or the internal sphincter, the pelvic floor muscles in a woman, and in the outlet in a man includes the prostate, the bladder neck. They also have this kind of internal or intrinsic sphincter down here, and the pelvic floor muscles as well. And that kind of summarizes just the bladder outlet. Here's a more anatomic look at a male's lower urinary tract, the bladder here, prostate here. It rests right underneath the bladder neck and compresses the urethra. If it gets too big, it's going to actually narrow and obstruct the urethra. Then we have the pelvic floor here, and there's also an internal sphincter here as well. So if you, as a surgeon, were to take a prostate out, do a prostatectomy for prostate cancer, you are dependent now on this small kind of intrinsic sphincter here when you sew the bladder back to the urethra. So men after prostatectomy actually kind of have a more female sort of physiology and anatomy now, because they don't have that extra sphincter that the prostate gets them. So men, you don't really think of having what we call activity-related or stress urinary incontinence until after they've had their prostate surgery, which can kind of result in that issue as well. Their outlet is much weaker after removing their prostate. Beforehand, the prostate actually gives them increased continence. And then again, this is a probably way more complicated picture than we need, but it just sort of shows you the complexity of the outlet, even in a female patient. And it's a lot of muscles. And so as patients age and they get muscle weakness and atrophy, you can see some deterioration of the outlet in women as well. So you have I think this is a better picture, the bladder here. These are the muscles around the urethra that act as a sphincter to compress the urethra and keep it closed. And you have the pelvic floor muscles here. And I don't expect you to really remember any of this, but it's just kind of a picture of visualization of the outlet. And this is probably more important. I want you to kind of remember this picture. So this is a picture of the pelvis with everything taken out of it. And these are the pelvic floor muscles we talk about, the Kegel muscles, which will ultimately be useful in both patients with what we call activity-related leakage as well as urinary urge incontinence or an overactive bladder. So through these muscles, you have the urethra right here. This is obviously a woman. You have the vagina here, and you have the anus here. And these muscles, they act like a sling. We talk about sling surgery, and we're trying to kind of mimic these muscles, and they attach to the pubic bone here, and they go around the urethra like this. So when patients cough or sneeze, these muscles are supposed to tighten and pull the urethra up and compress it and kind of kink it. And that's why if your muscles are functioning and intact, oftentimes you won't see that leakage with activity, whereas after childbirth and even aging, these muscles may not function as well, and you may not get that extra elevation or kinking of the urethra. But those are the muscles. And so sometimes when I'm trying to teach patients how to do Kegel exercises, if I can't get them to tighten on their own, I might talking about, well, what would you do if you were trying to trying to prevent yourself from passing gas? And that will still allow them to access those same muscles, because when you're tightening the muscles around your anus, you're still going to be tightening the ones around your urethra as well. Okay, this is probably more than, again, you need, but these are just showing sort of the fascial attachments to the pelvic organs in a woman. You might see a patient with pelvic prolapse or loss of support to the vagina and resultant loss of support to the bladder. And that's these blue kind of drawings here are ligaments that attach the vagina and the uterus to the pelvis, and the bladder rests on that platform there where the vagina is. And so these can all be injured at the time of pregnancy and childbirth and cause some loss of support and ultimately some loss of continence. Okay, so again, just another sort of picture. This is a female urethra. So women have this, what we call intrinsic sphincter, and that's just the coaptation of the urethra itself, but that is part of the bladder outlet augmented by the pelvic floor muscles, which are actually on the outside of this urethra. So, and as women age, sometimes you lose some of this vascularity, this fullness. It's thought to be possibly a result of decreased estrogen levels, and so you may not get as many wrinkles. This is one place where you want wrinkles as you age. You don't get as many wrinkles here and as much closure of the urethra when these sort of wrinkles smooth out and the vascular tissue sort of atrophies. So this is a part of that outlet in women. So you have anatomy that's important for continence and different problems with the anatomy that may lead to urinary incontinence. But the other thing that is involved in this whole process are the nerves. And again, I don't expect you really to go through all this, but just know that the bladder actually is one of the few, it's actually, I think, the only organ that you actually have voluntary control over. And in utero, the nerves are not hooked up yet. And actually, the nerves don't get hooked up till we're about 18 months to 24 months. So you can't really toilet train a child until they're about that age. And the reason is because the nerves have just not matured. The system hasn't developed yet. And so once those nerves get hooked up, you can start to toilet train a child. And then you actually have, as an adult, a fair amount of voluntary control over the bladder. And it involves in a sense, the entire spine, although the major offset of the nerves are below T10 and below. But those nerves run up the entire spine. So any injury to the spinal cord, any neurologic disease that affects nerve function can affect bladder function. And then obviously there are two centers in the brain. There's the voluntary cortical voiding center, and then there's the pontine nucleus, which is a coordination center. And so anybody who's had a stroke, and there's loss of function between those two centers, is going to have bladder dysfunction. Usually if there is a brain injury, you're going to see loss of voluntary control over the bladder, and it will resort to a more reflex kind of voiding pattern where the patient doesn't have any control and the bladder just empties without their permission. So anything that affects the autonomic nervous system, the parasympathetics, the sympathetics, which a lot of the medications that our older patients on will be affected by this, as well as muscular function down here in the pelvic floor. So it basically involves the whole nervous system. And again, just a little bit more simplified kind of picture. So most of the nerves to the bladder come off the lower spine, no higher than about T10. And then you have the centers in the brain. But again, these nerves travel all up the entire spinal cord. So again, any level of injury to the spinal cord can be an issue. I get asked a lot of time whether someone's back injury, like they have back pain, they may have a little stenosis at some nerve root is causing their urinary incontinence. And I always tell patients, I said, don't go have back surgery. If the only reason you're thinking about having back surgery is to fix your urinary incontinence, do not have back surgery for urinary incontinence, because there's so many reasons you may have urinary incontinence. I mean, obviously, if you're having loss of significant motor function, clearly reason to intervene, but not for urinary incontinence. I would not, if that's an isolated symptom. So we have the nerves and we have the anatomy. So we put this all together and you end up with what we call the micturition or voiding cycle. And so very, very generally, as the bladder fills, this is actually a line depicting bladder pressure. The bladder fills under no pressure. It really should be a big, floppy, compliant thing, and it fills without pressure because the kidneys drain largely by gravity. There's no engine pushing urine from the kidneys into the bladder, unlike the bladder that has some squeeze, which will actually push the urine out of the bladder. So we need a low pressure system. So as the bladder fills, pressure is low. And as the bladder starts to fill, you should reach some threshold that will give you a sense of needing to void. And then you will end up with a normal desire to void. And at that point, when you give yourself permission to go, the bladder starts to contract, the bladder pressures rise. Once the bladder is empty, the pressure decreases again, and the cycle starts all over again. But as the bladder fills, the outlet remains or should remain closed, and actually the pressure in the urethra actually increases as the bladder fills because it's being asked to do more. It's being asked to hold back against more. So again, that is all, we are able to do that because of an intact nervous system and an intact anatomy allows us to do that. So what happens when we age? There are lots of changes as we age to the lower urinary tract system. First off, the bladder actually can become a bit more stiff. It doesn't want to hold as much urine. The bladder muscle actually gets weaker. You don't really talk much about detrusor failure like you talk about, cardiac failure, but the same thing can happen. So we see patients whose bladder just doesn't squeeze as much as it used to. It doesn't want to hold as much. And so you start seeing urinary frequency, and then you start seeing incomplete bladder emptying and what we call elevated PVRs or elevated post-void residuals. And that's oftentimes a lack of bladder contractility. It can be difficult to differentiate that between outlet obstruction in men, and men can sometimes have both. They can have a weakened bladder contraction as well as some obstruction. In women, unless they've had surgery, it would be very unlikely for them to have an increase in their outlet resistance or obstruction. Usually in women, if they have an elevated residual or aren't emptying well, it's because their bladder muscle, or what we call the detrusor, has simply decreased in function. So, and also so in talking about the outlet, we need a certain length in our urethra to help maintain continence. So the urethral length can decrease, the closure pressure can decrease, and that's a result of loss of that vascular kind of cushion that you saw on the intrinsic sphincter picture, as well as decrease in muscle function and weakening of the pelvic floor. And again, the other thing that happens as we age in men, thank God I don't have a prostate. I'm very happy about that because the prostate enlarges in most men. And what happens is it starts encroaching on that urethra, and it takes more and more pressure to actually get the bladder emptied. And what you can see in men is that as the prostate enlarges, the bladder, because this happens slowly, will start to get strong. It will hypertrophy and actually get stronger up to a point. But the bladder can only get so strong. And so you get to a point where the bladder contracts and starts to kind of tip over, that just cannot get any stronger. And then that's when you start to see men with increasing residuals, increased slowing of their urinary stream, and more difficulties. So we want to try to catch those patients before they kind of fall over into that, starting to have detrusor failure. Okay, so Nocturia is a big topic, and there are now 2 new drugs out. They are really just they're just Desmopressin, but they've kind of repackaged them in lower dosages, and Desmopressin is the antidiuretic hormone, so it prevents you from making urine in a sense. it allows you to retain free water, which you might go, what's that going to do to my sodium? And maybe I don't want to cause hyponatremia in my older patients. Anyway, it's a big deal now, and part of it's being driven by these newly packaged drugs. But it is a problem, and it is a problem in the elderly. And what you have to realize is that oftentimes nocturia is not a problem that the urologist actually primarily deals with. I mean, I deal with it all the time, but you have to look outside the urinary tract system, because as people age, it oftentimes isn't the bladder. I mean, it can be sometimes, but you have to think about sleeping issues. You have to think about fluid issues. You have to think about venous insufficiency, renal and heart disease. And so I will tell you that if you look at polyuria or nocturnal polyuria, there is actually a definition now. And what you do is you do avoiding diary for 24 hours, which can be really challenging to get patients to do. But the definition is you shouldn't make more than 1/3 of your urine in your sleeping hours. And I've seen diaries where patients are making like 3/4 of their urine at night. So obviously, if you're making 3/4 of your urine at night, you're not going to sleep very much, because the bladder can only hold so much. So, but just be aware that there are a lot of factors outside the bladder, and the best thing, if you can get it, is a diary. And sometimes the accuracy you have to question, but anyway, it is normal. Well, it is relatively normal for elderly patients to get up once to twice at night, just because of these issues we talked about in terms of venous insufficiency. Your kidneys actually don't concentrate the urine as well either, so you do make more urine at night. And then again, also along with this, the bladder again may not hold as much. You may not be emptying as well. So all those things contribute to nocturia. And I think a great deal of people don't sleep as well. So they think, oh, I'm already awake, I might as well go empty my bladder because I don't want to have to go in an hour. So some of it is also sleep dysfunction as well. And the other thing I didn't mention on this slide is anybody who has obstructive sleep apnea. We know that those patients actually, if it's untreated, will make more urine at night. A diuretic peptide is released when the heart is kind of fighting to push the blood around. And so if those patients are treated for their sleep apnea, you can oftentimes see their nocturia go down as well. Another thing to keep in mind. So just in terms of when you're seeing a patient, I try to classify people into different types of urinary incontinence. And here I've put them into kind of two categories. These are sort of what we usually think about clinically. And these are kind of like, is this a problem transient? I mean, is this something that's going to go away, or is this a chronic problem and it's established and it's not going away? And for the elderly, I want to spend a little bit of time talking about functional incontinence, because it's much more of an issue in elderly patients than it is in your younger patients. And I will say, even though you can have transient stress incontinence and transient urge incontinence, the vast majority of people who have a temporary problem with urinary incontinence is much more of urge incontinence. It's bladder irritation from like an infection or having a stone in their bladder. You can also see it in men with prostatic hypertrophy who are not emptying their bladder well, and they're kind of having what you call overflow incontinence, and they're leaking over the top. That can be transient if you fix their obstruction. It's rare that you're going to have transient stress incontinence. It's just, I was trying to think of an example, and I'm like, I can't even think of one I've seen recently. So anyway, so we're going to move on to, so what is stress incontinence? It's not because you're stressed out. It's not because you're nervous, because actually there are some patients whose frequency increases if they do get anxious, but that's not what I'm talking about. I'm talking about you're putting stress on the pelvic floor. So it's increase in intra-abdominal pressure. So it's leakage with activity. It's like coughing, laughing, sneezing. And it's not a problem of the bladder. It's a problem of the outlet. It is the second most common cause of incontinence in older women, the first being an overactive bladder or urge incontinence. Stress incontinence is a result of weakened support to the urethra or the sphincter, and we kind of talked about that on those anatomic slides. And as I said before, men can experience stress incontinence, but it's typically after the urologist has gotten a hold of them, whether we've taken the prostate out or we've actually eliminated some of the prostate tissue with a urethral resection. If you see a guy who you think has stress incontinence and he hasn't had urologic surgery, then you may want to start thinking about a neurologic disease, because you could see stress incontinence. It would be really unusual in a gentleman with a significant neurologic disease. So this picture is, again, just a depiction, I lost something, of why you have leakage with coughing, sneezing, laughing. So this is a picture of the pubic bone here. Here's those supportive fascial structures. Here's the urethra kind of laying in that on top of the vagina. And this side, everything's intact. Well, this patient has had a rupture of this attachment to the pelvis and the muscle, probably after vaginal delivery and now aging. And now the urethra doesn't get that compression when someone coughs. It's not elevated. This side is not supported. And you can kind of see this picture here. Here's the bladder, here's the pressure being applied, and this wall, because of that weakness to the vagina, is allowed to descend and patients will leak. So when you're doing an exam, you can actually see, this is a female urethra here, the labia, and normally you shouldn't see the anterior vaginal wall on exam, but this is a woman who's coughing and straining, and you can watch that anterior wall come out towards you. Even if you don't see urine leakage from the urethral meatus, you can appreciate that. And I actually frequently have patients urinate before I examine them because I don't want to get my shoes wet. So I can see this come down and it's okay. That still tells me what the problem is. And it's just another depiction. So you can have a support problem. You can also have weakness to the intrinsic sphincter. And you can see this is a nice plump urethra and this one isn't so good. So there are treatments to try to kind of bulk that up as well. And that is typically more of an aging issue. Sometimes you'll see this after radiation, pelvic radiation, the tissues are caused to shrink and fibrose, and you can see the same issue here. So stress incontinence, outlet problem, support problem, urge incontinence, or what you may see the term, there's so many terms here. Generally, people are using the term overactive bladder rather than urge incontinence. The trick is people use the term overactive bladder for patients with your urgency frequency without necessarily incontinence. And at one time they were using the term overactive bladder wet and overactive bladder dry. I think those are really unhelpful terms, but bladder overactivity with incontinence is kind of what we're talking about. And that's generally where what's happening is the input from the brain is not, the bladder basically is not listening to the brain anymore. And when the bladder decides it wants to go, it will just go. Some patients will get a little bit of warning. They may have no sensation. Then all of a sudden they get this really strong urge to go. And if they don't get to the bathroom right there or can't contract their pelvic floor muscles, they will leak urine. That sudden, out of the blue, really strong urge, that's not this normal sensation of, oh, my bladder's getting full. It's the bladder already trying to go. It's like, no, I'm not giving you warning. I'm just going and you can deal with it is sort of what happens. Whereas normally on those past slides, what we were talking about is you should actually get an early sensation of, oh, you shouldn't know you have a bladder until it starts to reach fullness. Then you get a warning of like, oh, my bladder's getting full, but nothing's happening. So it's just this, my bladder's full. And if it goes immediately to, oh my gosh, I got to go, where you want to like dance around and tighten your pelvic floor, that is an involuntary bladder contraction, which is what is happening when we talk about urge incontinence. The bladder is contracting without the patient's voluntary permission. It is the most common type of leakage in either sex, male or female, as we age. And again, there are many terms. If you see the term detrusor overactivity, that is somebody who said, I've done urodynamics, which is an invasive, fairly complex study proving that this bladder is contracting without the patient's permission. Generally, the term you're just going to be using is overactive bladder urge incontinence. So, and then overflow incontinence is basically a bladder that's too full and a little urine comes in and a little urine comes out, like a very full teapot. And that happens in the face of a bladder muscle that doesn't work very well anymore and it's not able to push the urine out. You can see it very commonly in diabetic patients, because what happens with diabetics is it takes more, they have a neuropathy, and it takes more and more bladder distension for them to feel their bladder, to feel like they need to go. And eventually, if you think about it like an elastic waistband, if you overstretch that a lot of times, eventually it's not going to come back. And that's what happens with the detrusor or the bladder muscle. It gets overstretched. Eventually, it's so overstretched that it loses its contractility. Now, it's not uncommon for this to happen immediately after surgery because of all the things that are going on after surgery. So we see this not too uncommonly. And if it's an acute obstruction. Generally, patients will recover very well from that as long as their bladder's drained. But patients who have what we call chronic obstruction, where it's happening slowly and the injury is over a significant amount of time, it can be harder for that detrusor to recover. Not saying it won't, but it can be more difficult for that to recover. Overflow incontinence can happen because the bladder is not contracting well, i.e. with diabetes or obstruction, as well as if there is an obstruction at the bladder outlet. In men, that is most commonly seen with prostatic enlargement. You can also see it with urethral stricture disease as well. Anything that's going to block the urethra. In women, again, generally you are going to see that in patients who have actually had incontinence surgery. So when we do urinary incontinence surgery, we don't have the skill to allow that sphincter to open and close as it naturally does. And so what we're doing is we're tending to make it a little bit more obstructive so that patients don't leak. So if their bladder doesn't come around, oftentimes the surgery that we have performed may actually cause them to have difficulties voiding and could end up in bladder outlet obstruction and overflow incontinence. So we need to be concerned about that. So the one thing is, just to keep aware of, in your elderly patients, if they don't have a long history of urinary incontinence, but all of a sudden they develop urinary incontinence and it's a rather abrupt onset, you need to kind of think about what precipitants may be outside the urinary system. I take a lot of histories of patients who say, oh yeah, I've had a lot of little leakage for years, but 2 weeks ago, I just started leaking an incredible amount. And so that may be a transient issue. Maybe there is something that's happened that you can correct that exacerbated those symptoms to be much, much worse. So you need to think about that. Is there a medication? Is there an infection? Could there be a stone? What's happened? Maybe we can fix that rather than it just being a worsening of their chronic or established kind of incontinence. Because typically stress incontinence from a weak outlet or overactivity that's chronic doesn't acutely worsen unless something's happened. So this is kind of a list of those things that might exacerbate incontinence, and that can be transient. So obviously, if you have a confused or delirious patient, not aware where they are, they're not going to make it to the bathroom, they're going to be able to express that to you. Infection can be a cause of transient incontinence, but I want to give you a big red flag about this. We are really trying not to overtreat bacteriuria, particularly in the elderly population. And it's a fine balance in when you treat, when you don't treat. But the rate of asymptomatic bacteriuria or bacteria in the urine in the elderly population is actually very high. And as long as they are not having symptoms, they're not feeling ill, we don't treat it, and we recommend not treating it, just trying to not increase the bacterial resistance and cause side effects, etc. So I do, if I have an older patient who comes into my clinic and they're seeing me for urinary incontinence and they have bacteria in their urine and they've never been treated, that bacteria, I usually will treat them once just to see if that helps with their incontinence. And if it does, then we got to figure that out. But generally, it's not going to make a big difference in their incontinence. So I don't continue to treat them for their bacteriuria if incontinence is their only symptom and they saw no improvement with treating the bacteria in their urine. Atrophic vaginitis, elderly women can have basically a thinning of their urethral tissues. There is some evidence that actually giving estrogen back to women who are postmenopausal and having overactivity, you can actually see some improvement in that. The bladder has a lot of estrogen receptors, so that can be used in that. We talk about pharmaceuticals. I mean, unless it's like an acute, like narcotic issue, I mean, I find that oftentimes I can't change the drugs. If a patient associates the onset of their symptoms with a particular medication, it's hard to change that. I kind of have to work with that. I will say with diuretics, what I sometimes do, if patients are complaining of nocturia and they're already on a diuretic, usually they take it in the morning. And so they get rid of their excess fluid in the morning. And then by the time they go to bed, they've already gathered up all that fluid again. And so I suggest that they take it early afternoon so that hopefully they can get rid of their diuresis and not recollect that third space fluid before they go to bed at night. So that's the one thing I can do with pharmaceuticals. You might think, okay, obviously restricted mobility is a kind of a no-brainer. If you can't get out of bed and you can't get to the toilet, no matter how good your bladder is, you're probably going to leak. And stool impaction, though, is something to also think about. Stool impaction, what oftentimes happens with severe constipation is the pelvic floor muscles are tight, trying and being irritated by this full rectum, and patients have difficulty relaxing in order to urinate. So you can see overflow incontinence with stool impaction. Sometimes you see overactivity, but asking about bowel function is important in these patients, and trying to treat constipation and stool impaction can be helpful. This is just a list of some of the medications that may affect continence. I'm not going to go into a great deal of them. I find obviously some of them are just obvious, and the others oftentimes you can't change, so you work around them. So what is functional incontinence? And functional incontinence is just a very straightforward issue where literally the patient is not really functioning well enough to actually get themselves to the toilet. And, you know, we talk about it more in the geriatric population, but you can see, I mean, I just had a woman the other day who was like going to have her both knees done, and she already had a little bit of overactivity, a little bit of incontinence. She was really worried about how she was going to get to the bathroom on time. So we kind of problem solved together about how she could manage that with her limited mobility. But the interesting thing is, and even in this study that was done by Resnick, it was a long time ago, but looking at geriatric patients who were severely demented, there was a huge portion of incontinence. But if those, of the patients who could still, with those cognitive issues and psychological issues, if they could actually transfer themselves from the bed to the chair, you could make them continent. So there are some issues. The other thing that I frequently do when I have an older patient is when I'm seeing them in clinic is I actually watch them get up from their chair, stand, and walk across the room. And I kind of time that, because as a provider, I oftentimes walk in the room, the patient's already, you know, on the chair, our exam table. I go out, I have the nurse, you know, help them get a urine specimen. I don't ever see any of that. And it's amazing how long it can take for some patients, and physically struggling to get up. And then some of the patients will have stress incontinence just because they have to make so much effort to get themselves out of the chair that they are really valsalving in an attempt to get out of the chair. So it's just sort of eye-opening sometimes, and you kind of go, oh, well, let's see what we can do to help that. Sometimes it's a bedside commode. Sometimes it's actually sending them to physical therapy, not only to strengthen their pelvic floor, but to actually do general sort of strengthening and trying to figure out, you know, what kind of assistance might allow them to get to the bathroom in a more timely fashion. Again, so this is just sort of a diagram of what this looks like, all the different factors that play into it. And this is clearly more of an issue in the elderly population here, because they're on more drugs, they have more functional issues, they got more neurologic issues. So, okay, so what do we do when we have a patient in the office? The first thing is, this is not cancer. I mean, I have talked about how it's costly and it can affect quality of life, and there actually can even be some medical complications from urinary incontinence, but it isn't cancer. And so I try to, first off, what are the patient goals? I mean, do you just want to be able to walk down the hallway and be dry? Do you want to get to your grandson's graduation? I mean, how far do we want to take this? Then kind of try to identify any possible transient issues, because those are correctable and give us hope to make things better. And then assessing the environment and support if you need to. So history, straightforward history, but then you want to pay attention to kind of the voiding pattern and the type of incontinence. And I will tell you, the history alone is the most sensitive test for eliciting overactive bladder. So basically, if a patient tells you, I can't get to the bathroom on time, my volume that I leak is large and intermittent, that is an overactive bladder. You just don't see that with stress incontinence. Typically, stress incontinence is small amounts, tends to happen. I mean, it can only happen in the face of activity. So large volume intermittent leakage is typically an overactive bladder. I will also tell you that in the elderly patients, sometimes they don't give you that urge. They just don't get the urge. They said, I'm just standing there and all of a sudden all this urine is coming out. Again, if it's large volume, intermittent, it's going to be an overactive bladder. And there are all these fancy tests we do, but to be honest with you, if you do this test called urodynamics, where you take a patient back and you put catheters everywhere and you try to document that they're having these involuntary bladder contractions, 30 to 40% of the time, you're not going to see them because they're so inhibited and thinking about their bladder. So history is really the most sensitive test for that. And some of the other issues you want to talk about with patients, it's good to kind of talk about frequency. How often do you urinate? Thing I ask all the time is, well, why do you, if frequency is what's bugging them, they're like, well, why do you go so often? And generally there's sort of three answers you're going to get. Well, if I don't go so often, I'm going to leak, and that would be, okay, overactive bladder. If I don't go, it's going to hurt. And that falls into this more painful bladder syndrome, and we're not going to talk about that today. And then the other option is it's just annoying. I can hold it. I'm not going to leak, but it's just annoying. And there are patients who have this sort of bladder hypersensitivity where the sensory threshold has been decreased, and you can actually work with those patients as well, but it's not pain. So frequency, it's always helpful to know why they go so often. And then obviously it's helpful to know how much fluid they're drinking. And sometimes, a lot of times patients have no clue, and that's why avoiding diary can be incredibly helpful. And they come in all shapes and sizes. It doesn't really matter. You just need to know a piece of paper. You try to get patients to write down how much they drink and how much they urinate. And this can be an incredibly challenging thing. This one's really complicated. I try to make it as simple as possible because it can be really challenging for patients to do this, but it can be incredibly helpful and eliciting to both the patient and you. And you may be able to pick up some triggers. Again, if there's this whole thing called the front porch syndrome, and one patient described it as, my bladder must have eyes. But it's amazing trigger. Patients get to the front door, they put the key in the door, and all of a sudden they got to go to the bathroom. And I'm not sure what that is, but it's a true phenomenon. So if they would just urinate before they get in the car, or as my friend did, who just built a bathroom in their garage and said nobody can use that but her, you can do that too. But so she was able to manage it by having a ready bathroom and expecting it. So on physical exam for incontinence patients, you don't have to do an extensive exam, but it's mainly looking at the abdomen, see if you can palpate the bladder, which is actually very hard to do. And in most days, we either pass a catheter or we have a little ultrasound machine to see if the bladder is really full. You want to look for evidence of neurologic disease. I definitely recommend a pelvic exam and a rectal exam, particularly in men, looking for some of those weaknesses in support, looking at the tissues. The other thing is that I'll have it in the picture exam, the next one. And then you also want to look for, again, lower extremity strength. Can they get up and down from a chair? Can they walk quickly enough to get to the bathroom? Is there an extreme amount of lower extremity edema? Those patients are probably going to have trouble with nighttime frequency, because all that fluid is going to come out of their legs and back into their bloodstream, and they will need to get rid of that if they have significant edema. So this is a female pelvic exam, things that you would be looking for. So in an elderly patient, if you're thinking about maybe estrogen would help this woman, you're going to look for vaginal atrophy, which would show up on exam. Tissues tend to be paler, although sometimes they can be actually redder than normal. The tissues have thinned. The rugae in the anterior vaginal wall tend to be thinner. The labia may be even agglutinized to the labia majora and thinner. You can sometimes in women see this little red thing, which is actually, it's called the urethral caruncle, but that's actually the urethral mucosa being exposed, because as the female genitals atrophy, the outer tissue starts to thin and pull back, and you start to see some of the urethral mucosa. It's not a problem. It just sometimes looks bad and people get concerned about it. And I've lost my hair. Oh, there it is. So on exam, you want to see, do they leak when they cough? Just get out of the way. You also, if you have an empty bladder, you can actually see if the anterior wall comes down and when they cough and bear down on exam. The other thing you want to do on a pelvic exam is also take the time to actually see if patients can do a pelvic floor contraction, because if they can locate or isolate those muscles, you can actually almost just hand them an exercise sheet and say, here, go do these exercises, and this can help. A lot of patients, and probably more so in the elderly, they cannot localize these muscles. So if you just tell them to go do Kegel exercises, they're going to waste a lot of time and get frustrated. So I always check when I do a pelvic exam, can this patient isolate her muscles? And if she can't, then I will send her off to the physical therapist if she's interested in using that as a tool to help her incontinence. So, because the physical therapist has all sorts of ways of getting patients to tighten those muscles. The other thing I'll just tell you that physical therapists do, this is a functional problem. So just sitting there and doing Kegel exercises while you're sitting doesn't necessarily take care of the problem when you're upright and moving, and the physical therapist works with that patients to help them figure out what they have to do as they're moving and getting up from a chair, etc., to help control their incontinence by tightening their pelvic floor and in movement, not just sitting. This is just another example of sort of some of the instruments you can use to look at a female, when you're doing a female pelvic exam. What I frequently do is I separate the speculum and I just use the posterior blade and I place that in along the posterior aspect of the vagina, and that allows me to see the anterior wall. If you put the speculum in with both blades, it's going to hold up the bladder and you won't really be able to see this movement. So you need to kind of do something to allow that anterior wall to come down. And then if you think that they may have weakness to the back wall, you can flip it around and put that blade against the bladder to see if the back wall comes down. That's what you might see with a rectocele thing. I would suggest not doing the Q-tip test. No woman likes to have a Q-tip stuck in her urethra, and it doesn't really matter if it moves or not. You can tell that by just examining the anterior vaginal wall. In men, definitely you want to do a rectal exam, evaluate the prostate, and also actually look at the urethral meatus. Some men can end up with meatal stenosis or narrowing, and that can inhibit, make voiding difficult, so it's worth doing both. Other diagnostics for incontinence, you want to make sure patients are emptying. So I have patients do a post-void residual. Post-void residuals, particularly in guys with prostate issues, are not very accurate if they don't really feel like they need to urinate. So I always stress, if I can, or at least I want to check in with a patient to say, did you really need to urinate? Because I want you to really feel like you have to go urinate, and then we'll check a residual. Because oftentimes if there's very little urge to go and they're just trying to be a compliant patient, they'll go a little bit, but leave a fair amount behind because they just didn't really have a strong urge to go. And the bladder depends on being stretched in order to trigger those reflexes that allow it to work well. So, and post-void residuals are really, I mean, they're variable. Some days people empty better than others. So before I get too concerned about a residual, I may do it a couple of times. And everybody always asks, well, what should a residual be? And it really depends on how much urine the patient has or what their normal bladder volume is. So generally, if someone's voiding 2/3 their bladder volume, they're going to be successful in voiding. So it's not like a magic number, although a lot of people sort of use 100 cc's as kind of their bottom line that you want to see at 100 cc's or less. But I have patients whose bladders hold 200 cc's, and if they leave 100 cc's behind, that's not very good. A stress test, all that is now you have a patient with a full bladder and you have them cough and sneeze and just see if they leak. I tend to have patients leak more when they're standing. So I basically have them stand over a blue pad or something and have their shoes off and just see if they can leak. You do want to do a urinalysis and a urine culture. If there's evidence of infection, obviously you need to address that. The other thing you're looking for in a urinalysis would be an elevated glucose as an indication for diabetes, which can lead to issues as we've talked about. You also want to look to see if there's blood in the urine. If there's blood in the urine, those patients need to be referred on for further evaluation. Serum creatinine if there's any concern about renal disease, and glucose if you're worried about diabetes. Urodynamics, I'm not going to go into a great deal. It's just much more of an invasive study that we do to evaluate bladder function if need be. We're getting away from not doing it nearly so often. It's not actually generally done before women are having their first incontinence surgery. As I said, rarely need to do it for patients you're suspecting an overactive bladder. I tend to do most of urodynamics in patients who have significant neurologic disease, because you can't really kind of tell sometimes by history what's going on. And then in gentlemen who are thinking about whether they're in retention and thinking about whether they should have an outlet procedure, because if this is a chronic problem and their bladder is not working anymore, then even if you get rid of the obstruction, they still may not urinate adequately. So that may help them make a decision about whether they really want to have a procedure or not. So sometimes we do urodynamics to see if the bladder muscle is still working. So therapies for this. So detrusor overactivity. For any incontinence, we always sort of start with behavioral therapy. How can we modify what a patient is doing to help them with incontinence without having to take medications or do further? So for detrusor overactivity, simply preemptively voiding. In other words, don't wait for an urge to go. Go before your bladder decides to go. And that sounds like it would work, but I'll be honest with you, there's so much variability in urge incontinence that it can be difficult for patients to do that. And sometimes it means they're having to void every hour, and that's not really practical. Or you could do pelvic floor muscle exercises, and you might think, well, why would you do that for detrusor overactivity? Well, basically, tightening your pelvic floor does not change the bladder from trying to go, but what it can do is if you get an urge to go and you tighten your pelvic floor, you're going to shut off the urethra. And so even if the bladder is contracting, you may either stop or limit the incontinence that you have. And so it does work. It can be a useful tool for both kinds of incontinence, both stress and overactivity. There are medications and there is neuromodulation, and there are 3 types of ways of affecting the nerves to the bladder to get it to work better, and we'll go into a little bit more detail here. So diet modification falls under that behavioral therapy first-line treatment. So again, if you're trying to reduce nighttime frequency and some of the overactivity that might be coming at night, you want to decrease the fluid that patients are drinking at night to help decrease their urine output at night. So we talk about stopping fluids about 3 hours before bedtime, which seems to be reasonable. There is not a lot of data supporting this, but anecdotally, and patients tell me all the time, eliminating bladder irritants, typical ones such as coffee, alcohol, spicy acidic foods, all the good things. There are some patients, particularly as we age, that these things seem to irritate the bladder. There may be a slight defect in the bladder lining. Now the urine, these things in the urine can cross the bladder barrier and get in and irritate the bladder. So some patients find if they eliminate these things that they actually have better bladder control and they have less overactivity. Again, adding fiber to your diet if constipation is an issue can also be another thing to do with the diet. Other behavioral treatments, again, bladder training. So people talk about bladder training with overactivity, but I think it's more you want to do preemptive voiding, because if you start delaying voiding with urgency, those patients who have an overactive bladder are just going to go ahead and leak. So I don't quite understand that. If they're those patients who just have frequency but don't go on to leak, then yeah, that works. You can say, tighten your muscles, delay voiding, and let's try to stretch your bladder out a little bit so that you don't have to go so often. But those people who have true overactivity, most of the time, I'm like, no, go. We talked a little about the role of pelvic floor muscle exercises in this group of patients. Again, tightening your pelvic floor can stop the incontinence or limit it. But what you have to do, most patients' urge is to, when they get a sense of needing to go and they're worried they're going to leak, they just run to the bathroom. Well, it's very hard to tighten your muscles and run. So if you just sit there for a minute, tighten, breathe, what will happen is the bladder may try to go, but it finds this resistance and the bladder will stop trying for a short period of time. You have this little window because the bladder will try again if you don't act on it. But the pelvic floor exercises can be a useful tool. Not a cure, but a useful tool. And then some of the therapies that physical therapists will use includes biofeedback in those patients who just can't access their muscles. Behavioral therapy, so timed voiding, watching your diet, doing the exercises requires a lot of motivation. It depends, it's got to be pretty intense to get this done. It takes a lot of time, and if there's a caregiver involved in terms of toileting, preemptive toileting, it takes a lot of time to do that. And I know, so oftentimes it's not realistic. If you have a caregiver who's dealing with several patients, they're not going to be able to get to toileting that patient on a routine schedule, because it may be as often as every 90 minutes to 2 hours to make it work. And that's a lot of time. I'm not going to go through all. There's a ton of medications for an overactive bladder on the market, and most of them are anticholinergics with those inherent side effects. The shorter acting tend to have more side effects than the longer acting ones. I just want to point out Mihrab, and I have no association with this company. It is a completely different drug. It is a beta adrenergic, so it does not have the side effects of the anticholinergic medications. The problem is that there is no generic, and a lot of insurance companies don't cover it. Although even at the VA, I'm getting it covered now by saying my elderly patients shouldn't be exposed to more anticholinergics, and And so I'm actually getting it covered, but it can be difficult. This is just a picture just to sort of depict. So we have cholinergic receptors and we have beta adrenergic receptors here in the bladder. So when you stimulate the beta adrenergic receptors, what you're doing, and this is very subtle, you're encouraging relaxation because the sympathetic system is in charge when the bladder is filling, and the parasympathetic system is in charge when the bladder is contracting. And so when you're using the most common overactive bladder meds, they're you're using anticholinergics to block contraction. So, and there's actually a combo drug now. You can actually do both if you want to try to encourage relaxation and stop contraction. So that can be helpful. Side effects, the main side effects are anticholinergics that are well known are dry mouth, constipation. There can be blurry vision. And you know, there's literature out there now with dementia. I don't know if it's the greatest data in the world, and it seems to be more of if you're having on a lot of anticholinergic medications, but it is something that you have to be aware of. And my experience with the geriatricians, that is the first drug they pull off my patients anyway, who have an overactive bladder. It's like, oh, get rid of that one, get rid of that one. So anyway, there truly is some issues for some patients with central nervous system effects. So if you can avoid it, Mihrab, and you can get it, is a great drug to do that. Oh, and the other thing is for women, using some vaginal estrogen can be helpful. There's actually a small study done that in comparison to oxybutynin alone, and it showed about the same benefit. There have also been subsequent studies that showed a combination of anticholinergics and vaginal estrogen can be helpful. The thing about estrogen is vaginal estrogen comes in 3 forms. It can be cream, vaginal tablets, or a ring. Patients have to understand that it can take up to 3 months to see the benefit. And so you sort of do it for 3 months, and then it's the next 3 months you look at to see if there's any benefit. And Mihrab, as we've talked about, is a beta adrenergic. So it encourages relaxation. It was approved in 2012. It has 2 doses. It's a single dosage drug, 25 and 50 milligrams. And as I said, it can be difficult sometimes to get covered, but it's getting better because of the bad press on the anticholinergic drugs. The side effects of Mihrab were like raised heart rate, like 1 beat per minute. So if I have someone who's got major cardiac issues, got blood pressure issues, I sort of tell them to just just be aware of this and take it if they notice an increase in any cardiac issues, and they can stop it. But it is really a pretty benign drug. So when I have a patient with an overactive bladder, a lot of patients just want a pill and be done. The problem is that these medications, what they do is they help the bladder hold more and decrease the strength of these involuntary contractions. Doesn't necessarily improve their warning time. And so the most successful treatment in patients, if you're going to use medications, is to combine medications with sort of a timed voiding program and pelvic floor muscle exercises. So now you can start to see why, oh my gosh, if I have a patient who needs caregiver assistance for all this stuff, or is this ever going to get done? I have a rare patient who a medication alone will at least help, and sometimes even keep them dry, but I think that's the rare patient. So generally combination therapy is the best option. I just wanted you guys to see the drug, the Desmopressin drug. So the nocturnal polyuria, it's Noctiva and Nocturna. You just may see that out there. And again, it's to prevent, it basically causes the kidneys to hang on to free water so patients don't make as much urine at night. And generally this is seen in patients over 65. And again, the definition is if they're making more than 33% of their urine at night, then you could consider doing this for them. But you do have to watch out for hyponatremia or decreased sodium levels. So there is a recommendation of following their sodium a couple of times when they're on the drug to make sure it's okay. So another form of treatment, which is nice in that there is no drugs involved, is what we call posterior tibial nerve stimulation. So this is getting into the neuromodulation therapies for overactive bladder. And what you're trying to do is change the nervous system to work better. To be honest with you, nobody knows exactly how manipulating these nerves, why it works exactly. Studies have been done to show that it does actually change brain function. So it doesn't just work locally. the way I think about it, because these therapies that work on the nerves can help people urinate as well as not urinate so much. So it seems to kind of block the abnormal pathways and let the more normal ones go. The nice thing, so PTNS, literally, we use an acupuncture needle. You put it at the patient's ankle down here, and you're trying to reach the posterior tibial nerve. You hook it up to this stimulator. There's the grounding pad, and the patient sit there for 30 minutes. There's really no side effects. The drawback is, however, that it's a 30-minute visit. It requires a visit weekly for 12 weeks. So that's 3 months of commitment. And then there's a maintenance program. Medicare does pay for this. It's a maintenance program of once a month, once every 4 to 6 weeks, with the efficacy being about the same as oral drugs, but without the side effects. I will say there's this device called the eCoin that's in phase 2 or 3 trials, which actually is an implant that it's a little looks like a quarter that you implant at the ankle, and it's a continuous stimulation, and patients don't have to come in for treatment. So that may become another therapy that's more practical. I could sort of envision just, going to sort of skilled nursing facilities and maybe implanting these things. I don't know, but it's not here yet, but it should be. I would imagine it's going to be out in the next couple of years, if not sooner. That's what I was going to do. Oh yeah. So basically we don't need to do that. So this is just a graph of some of the early studies looking at sham stimulated therapy versus active therapy. So clearly there was some benefit. It's not perfect, but I've had patients who find it useful and helpful and keep coming back every month. So it's not fun to come to the university, so it must be doing something. Another more invasive type of therapy is where we actually implant an electrode alongside the S3 nerve root. It's called the InterStim. It's Medtronic makes it. It looks like a pacemaker. It has a generator and has this lead that goes through the S3 nerve root, and it has been approved for urinary urge incontinence, idiopathic urinary retention, as well as fecal incontinence. So it kind of treats all sorts of stuff in the pelvic floor. Again, I would say probably about 50% to 60% of patients find this helpful. There is a trial period. So before you implant the whole thing, you actually can have the patients try it out. It still means a procedure to have that temporary lead placed, but at least they haven't had the generator implanted. So you can try it in a sense before you have it implanted. And this is just a picture of the sacrum here, the S3 foramina, where we're passing this needle through the foramina trying to find the nerve, and this is the lead right there. We take this part out and the lead just stays underneath the skin where it stays sterile, and then we either connect it to an external wire during the trial or we connect it to the generator if it's a successful implant. And this is just sort of an attempt to try to discern how this may work. But again, nobody really understands it. And we know that it doesn't just work locally, it affects brain function as well. Right now, the drawback is that it is not MRI compatible, although they promised me in the next year they're going to have something that's MRI compatible. So patients who need MRIs are really not good candidates for that. I've had to take them out for that. Another way of dealing with overactive bladder, which works, we sort of call it a neuromodulator, is Botox. I'm not really going to go into how it works, but Botox is used for all sorts of things. In the urology world, we use it for the overactive bladder. And what you're doing is you're injecting Botox into the wall of the bladder and in a sense, partially paralyzing the bladder. And it works really well. Actually, about 80% of patients find this effective. The downside to it is it's not permanent. It has to be repeated, although in the bladder and the doses we use, it can last anywhere from 3 to 9 months. So it can be a 1 or 2 time a year visit. It can also be done in the clinic, although a lot of people still take their patients to the operating room to do it. It's a very quick procedure. And about 4% of patients, actually, it works so well on that they now have troubles urinating. And that's when you're really happy it's temporary, but it's about 4% of patients have difficulties voiding. And so this is just a template of what we do. This was the original description, and I do 30 injections in my patients who are already cathing and have spinal cord injuries as a rule. But sort of for the patient who has this run-of-the-mill overactive bladder, You generally inject about 10 to 12 sites in the base of the bladder. So here's where the ureters come in, the base of the bladder. This was just a study looking at durability, and at a different dosage. So generally for idiopathic patients, we put about 100 units in. For people with neurologic disease and are already cathing, we tend to put in 200 to 300 units in the bladder, and it still looks good at about, what is that, 36 weeks. So anyway, okay, urgent incontinence. I put this in here only because there are patients who require a great deal of care, and some of these things are just not practical. So where do I stand on catheters and urgent incontinence? When I have a patient who comes in with a catheter, sometimes, and I have no history and the patient can't give it to me, they just have a catheter and it's been in for a long time. The question is, well, is it in because you're leaking, or is it in because you can't urinate? And you would think that would be really obvious, but oftentimes it's not obvious at all. And so, I mean, there are patients who are managed with catheters. In my mind, an indwelling catheter is the last resort, but if it does allow freedom for these patients, I'm not horribly opposed to it if it's done in the right way and things are monitored. For men, you can use condom catheters, and that can be helpful. Women really don't have that option, although a patient of mine just showed me Stadium, it's called, what she call it? It's Stadium Gal, and it's this sort of like female condom catheter. It looks like it would not work very well, and it was $35 on the internet. Just saying, I have not seen that work very well, but there are such things. So I'm not horribly opposed to catheter, but you want to make sure why you're using it, what's the indication, what's the benefit, is this reaching some goal, rather than just making it easier for the caregiver. I mean, unless there just are no caregivers, and this is what you have to do. So moving on to stress incontinence, basically this is the weak outlet. This is a support problem, or it's a sphincter problem. And in general, it can be treated with pelvic floor muscle exercises. Again, physical therapy is a good option. People tend to get better faster with that. And again, you're trying to strengthen those muscles that surround the urethra and elevate it during times of stress. There are devices. We still use pessaries. Most people think about pessaries as intravaginal devices you use for prolapse, but we use them for incontinence as well. There's actually an over-the-counter product called Impressa, made by Poise, which is kind of looks like a tampon that women can use, and it's made for incontinence. The urethral insert is actually off the market now. It's not available. You can think about medications, anything trying to stimulate the sphincter. Alpha agonists can be helpful. I have several older patients on Ritalin. Now that is completely off-label, so don't go quoting me. I mean, you can quote me, but it is so off-label. But Ritalin is a really strong alpha agonist, and some patients with mild incontinence have found that to be helpful. There are bulking agents. What this is we actually take a scope and we put the scope in the urethra, and through the scope we pass a needle and we actually plump up the urethral mucosa. There are several agents you can implant underneath the mucosa, and that it makes it look like the patient now has a little prostate. So we're just bringing those edges together. Just like you can plump up your lips and your wrinkles, you can plump up your urethra, and that's an office procedure. It may not last it's not as it doesn't work as well as some of our surgeries, but it's a nice temporary kind of procedure. It also, in some of my older patients that I don't want to take to surgery, it's a nice compromise and it can be helpful. And then there are surgeries, and all the surgeries, no matter what you do, is to try to create that platform or that sling again. You're trying to arrest movement of the urethra so that it doesn't open. And I think let's see. So basically, as far as treatment outcomes, we don't really know for stress incontinence. There's really aren't a lot of behavioral things. Exercises, supposedly in some of the studies, about 50% of patients make it to a point where the incontinence is not a problem. Bulking agent injections, I think 80% is a little bit high, and this was old data from collagen. So about 60% of patients see improvement. I wouldn't say they were dry. Surgery, depending on the surgery, they're all about, in terms of efficacy, about the same, although durability may be a bit different. And depending on the studies you look at, I would say it's closer to like 60 to 85, 90% of patients are dry. Devices, obviously not as good. Pessary makes about 25% of the patients who try it dry, but you never know until you try it, and a pessary is a really benign procedure to do. And then again, medications can be used. There is some benefit, but not a lot of data on it. And I'm just throwing this mesh controversy in here. I'm not speaking about mesh at all, but I just want to make it clear. I think the media has made this somewhat difficult to understand. If you're at all aware, there's all these vaginal mesh lawsuits. The majority of them are directed at vaginal placement of mesh for prolapse, not for incontinence surgery. Those procedures and those materials have not been pulled, and we in the urogyn female urology field still consider the mesh slings as being the gold standard to some degree of surgeries. The complication rates are very acceptable. They're the most studied incontinence procedure. So if you have a patient who's thinking about surgery, I wouldn't just go, oh my God, have you seen all these lawsuits? And have you seen the FDA's are pulling all this stuff? There are some lawsuits that have included mesh slings, but the FDA just recently pulled these vaginal prolapse mesh kits, not the incontinence procedure. So just to kind of clarify that a little bit, there's still a very viable operation, at least at this point. They may at some point be pulled. The prolapse mesh procedures got pulled before the final data came out. So I don't know what's going to happen. As far as management for overflow incontinence, I cannot give you a new bladder. So if your bladder doesn't work, there's not really anything I can do. Now, if it's an acute situation, we can try to decompress the bladder, leave it to drainage, hope the bladder will recover. And there are some patients who even have long-term recovery of bladders over years. But the goal is you got to keep the bladder from being over distended. So you want to keep it under 500 cc's, whether with an indwelling catheter or clean intermittent catheterization. Obviously, if they've got overflow incontinence because the outlet is obstructed by the prostate, there are medications and you can do surgery to eliminate the obstructing tissue. Is that really it? Oh. Also overflow incontinence, well, we already talked about using a catheter. And just sort of in summary, because I run through a ton of stuff, I just want you to be aware that incontinence, although common in the elderly, is never normal and there are things we can do. The elderly are more prone to incontinence because of physiologic and anatomic dysfunction, as well as other medical issues that contribute to their symptoms, and need to also think about environmental issues. How far away is that bathroom? And so sometimes something as simple as getting a bedside commode or assistance in terms of getting out of bed can be enough to make the problem less. And we've already kind of gone ad nauseum over the evaluation assessment. But I do say it's not usually one simple thing you can do unless these patients have transient incontinence, like treating an infection or treating their outlet obstruction. Generally, it requires a bunch of little things to make patients better when it comes to incontinence. And I think that's about it. Are there any questions? Yes.
So it seems like a lot of these issues are age-related.
Yeah.
Is there anything that you would suggest in terms of prevention?
Okay, so the question was there a lot of these issues we've talked about are age-related, and is there anything you can do to prevent incontinence? That's a really good question. Nobody really likes this answer. For women, you might want to avoid getting pregnant and having babies. You'd like to avoid pelvic surgery. The other things is you want to avoid being overweight, so you should avoid being obese. That just puts more pressure on the pelvic floor. What's also interesting is obesity also plays a role in overactive bladder. And the thought is with this whole metabolic syndrome, there is some effect on the bladder as well. So we know that if people if they're obese and they lose 30 plus pounds, you can see improvement in their incontinence. So kind of general health measures, don't smoke, don't gain weight, don't get diabetes, and I think it'd be reasonable to start a campaign in junior high about doing pelvic floor muscle exercises personally. Maybe not so much for the guys, but for the women. Basically just maintaining, health is really what the big things. And, avoiding chronic cough, like don't smoke. How about let's smoke because all the time you've got a chronic cough that's just putting more pressure. Avoid constipation. Again, those that kind of chronic increase in intra-abdominal pressure and straining may be just like having, a baby. You're pushing that hard every day to have a bowel movement. So those things would be helpful in terms of prevention, obviously. Yeah, the healthier you are, the less likely you're going to have this problem. And I think the other big thing is, you know, getting hearing aids, getting glasses, you know, staying physically fit and really working with a strengthening program. I've seen elderly patients get a lot better. But just think about when they get sick and they're in the hospital, you know, they may have incontinence in the hospital, but when they get home and they rehab, that's not an issue anymore for them. So yeah, being healthy, biggest thing you can do. You don't have to stop coffee though. Unless you get the problem, then maybe you want to consider stopping it. But coffee doesn't cause the problem, so I'm not saying anybody has to give that up.
I don't have any questions coming in the chat. So
Okay. Anything else? All right. Well, good. We'll finish early, and then let's all go get coffee.
Get a comment. Excellent class, very good instructor.
Oh, okay. Well, that's good to know. I never know. Okay, good. You're welcome. I know it's almost too much, but I want people to at least have some idea what's out there. Okay.